Okay, everybody, we're going to go ahead and get started with today's webinar. My name is Edith Figueroa. Thank you, everyone, for being here for ACT's local community engagement to end the HIV epidemic in the US. So hopefully you're all in the right place. We have some very special guests from NASTAD and NACCHO joining the ACT Now and AIDS Coalition today. So I'm going to introduce them a little bit later, but to kick off the webinar, I'm going to talk a little bit about what the coalition is. So here are a few key folks in the coalition that made today happen. My name again is Edric Figueroa. He, him, or they, them pronouns work great. I'm the coalition coordinator here at ANEA. I'm joined by Jeremiah Johnson, the HIV project director at Human Action Group, and Jaren Benjamin, the vice president, community mobilization and national advocacy coordinator at Housing Works. So together, we kind of steer the ANEA ship alongside some of the committees I'll talk about in just a second. But before I do that, I just want to let you all know a few things. First off, the webinar is being recorded and will be made available after today. And there's also captioning available for folks who might need it. And this is something that we're going to try to have going forward on every ANEA webinar. So I'm going to put this link in the chat. I just sent it to Christina privately. I'm going to send it to everybody now. So if you need it, you can click on it and utilize the captions. So just to start us off with some interaction, I would love to know where everyone's coming from. Obviously, we can see your name on the attendees list, but in the chat box, which should be at the bottom of your GoToWebinar control panel, you can type in the organization, if it's applicable, that you're joining us with, and what jurisdiction you're joining from. So for me, Edric, ANEA, and I'm down here in Atlanta, Georgia. So folks will type in some responses in there. Would love to know who we have with us today. Thanks, Jeremiah. You don't have to be shy here. If you can type in there, please do. I'm wondering if maybe the chat feature is not working, because I'm not seeing a lot of responses. Yeah, it looks like I'm only seeing responses from panelists. Well, that must be a feature that for some whatever reason is not working. So what we're going to do is just move along with the webinar. We do have an opportunity to take questions from you all later. So we'll just have to have you direct message probably Jeremiah when we get to the Q&A portion later today, since it looks like only panelists are allowed to type into the chat right now. Okay, yeah. So Letitia's telling us that there's no chat feature. Are folks able to direct message people?
I think there's a question feature, Edric, but I'm not sure about the chatting. I'm always on as a panelist, so I don't know what it looks like for others.
Okay, great. I see the question feature here. So there's a question box at the bottom on your GoToWebinar control panel. There's the little left-hand sidebar, and at the bottom of there, you can type in questions there. So I've seen lots of responses here. Thank you so much, everybody. Looks like we have representation from New Orleans, from Pittsburgh, from St. Louis, from New York, from Virginia, and another person from Atlanta, great, and some folks from Arizona. Awesome, so we have a wide range of people with us today. Thanks for sticking through that with that hiccup. We'll just use the questions box going forward. So you're going to hear from me for about the next 7 minutes, and then we're going to kick it over to NACCHO and NASTAD to talk about their community engagement work as it pertains to ending the HIV epidemic in the US. And we'll hear from them till about 4 o'clock. We'll have some questions prepared for them, and a couple of you submitted questions in advance of this webinar, so I have those ready too. And then we'll close it out. So a little bit about ANEA. We're a national coalition of community-based organizations, health departments, national organizations, as well as HIV activists across the country working to end the epidemic in the US. And since its inception, we've really been focused on lifting up community voices, community leaders, and a community perspective to across all HIV ending the epidemic endeavors. So that's a couple of ways for us at the coalition. The coalition really came together as a result of the years of many years of activism across different organizations and jurisdictions. But at the 2016 USCA, it was officially announced that community activists wanted to work together to raise this community voice instead of having folks at HHS or on the federal level define what community means for us. ANEA strives to work from the bottom up. So community voices telling other people in power what the needs of community are as it pertains to ending the HIV epidemic. So some of the work that we do is we have a presidential legislative committee that's really focused on making sure that regardless of who is in administration, that ending the HIV epidemic is a priority. We released a roadmap that can be found online that it's pretty lengthy, but it sets out an ambitious goal to end the HIV epidemic by 2025. Everyone on this webinar probably knows we have the science to do so, and we just need the political buy-in. And we need to make sure that the most important communities don't get forgotten and that we do things through a racial justice lens. So I encourage folks to check that out. Some exciting updates to the roadmap are forthcoming later in the year. We also administer a small grants program. So to lift up community voices, we recognize that one of the things small community-based organizations don't often have enough of is resource and funding. So this year we kicked off our very first and hopefully not a last small grants initiative focused on making sure some of those voices that are left out of a lot of major ending the epidemic initiatives are brought in. So trans folks, Black folks, combination of all sorts of identities. We also want to be a source of technical assistance to jurisdictions who want to lift up community voice, who want to have a bridge between federal funders and agencies and their local community members. And we want to be putting forward things like this webinar. We want to make sure that community gets to talk to people that matter. And we all matter. Earlier this year, we launched our website. So you can check it out at anea.org and really get more of a sense of what's upcoming, what we've done so far this year. And there's also an opportunity to join us on there. So we really hope that you check it out. I'm definitely always open for questions or thoughts. Message us on there if you are so inclined to. And then some quick language things. I know we use a lot of acronyms in the HIV ASO world. So EHE, you'll see a lot today referenced in the presentations. EHE is Ending the Epidemic, a Plan for America, and that refers to the federal plan in this current administration has to end the HIV epidemic by 2030. It was announced in February of this year, and you can find that on hiv.gov. So before that plan, it was ever laid out, HIV activists were already using ending the epidemic as a framework to describe just the community solutions, the rights to science and actualizing the science that we have now to be an achievable end. So when we abbreviate ETE, we're referring to community-led initiatives. And when you see EHE, we're referring to the federal plan. It gets a little bit confusing, but hopefully that helps clear it up a little. So some context on this webinar. We are hearing a lot of confusion from community organizations that we work with about what they're supposed to do right now, since we are in the middle of a pandemic, when it comes to engaging those hard to reach communities, the communities that are disproportionately impacted by HIV, and making sure that those voices are centered and not left out of planning. So under the CDC's Notice of Funding Opportunities, both PS 1906 and PS 2020, state and local health departments were instructed to work directly with community partners on the federal EHE plan. So they were encouraged to establish new relationships with the communities that weren't traditionally funded by institutions like the CDC. So it sounds like an exciting and important opportunity to augment community voice. But like we said, we're just not getting uniform answers across the board. We did ask the question of all of you on this webinar if you had seen your draft plan, and the majority of you had, I think about only 10 of you who responded to that question said you hadn't seen it. 10 is still 10 too many because those plans have been out there for a while, especially under 1906, and some of them have already been reviewed by the CDC. And we know in order to successfully end the epidemic, we need community buy-in and we need community voice. So we're joined by NASTAD and NACCHO to talk to us a little bit about what their efforts to make sure that community voice is present looks like. So we're going to hear from Letitia Grant first. Letitia has over 8 years of experience working in HIV prevention, with the majority of her experience in state and federal government in public health. She has been with NACCHO for the past year as a senior program analyst, leading and managing the implementation of HIV-related project activities. Letitia focuses on priority areas such as local ending the epidemic efforts, PrEP implementation, harm reduction among persons who inject drugs, along with addressing HIV-related disparities and health inequities, especially among MSM, transgender women, people of color, and those living in the South. So, Letitia, I'm going to kick it over to you if you're ready to present.
Yes, thank you, Edric. I'll let you, there we go. And you have already introduced me, so I do not have to introduce myself. So we can move on to what is NACCHO. So on this slide, I just want to highlight, point out that NACCHO is the only organization dedicated to serving every local health department in the nation. And as an organization, we tackle all public health. We have a pronunciation here because a lot of times people call us NACCHO, but it is definitely NACCHO. And on this slide, it just shows the makeup of NACCHO. So I won't read everything, but it just shows our makeup: nonprofit organizations, students, former local health department officials. Next slide. Sorry, remember to say that to you. Next slide. So NACCHO, we consider ourselves the voice of local health departments. So that includes everything from advocacy, speaking on behalf of local health departments, writing letters of support on behalf of local health departments, educating Congress, providing training, policy statements, basically everything that has to do with local health departments and being that voice for local health departments. Next slide. And this slide, this is actually the team that I work on and lead the HIV portfolio, but we basically do everything on the previous slide, but specific to HIV, STI, or hepatitis. Next slide. So, Edric, we were kind of on the same page with our slides here. I put this here just to show, and everybody's probably already aware of all of the ETE plans that we have had in the past as far as ending the HIV epidemic, the National HIV/AIDS Strategy, jurisdictional, local, and state ETE plans, and then, of course, working our way down to on February 5th, 2019, the national ending the HIV epidemic plan. So once this came, a lot of us, and I say us, including myself, we wanted to know, okay, what is different now? You know, we already have all these plans. What is the difference here? So the key things that were pointed out was localization and community engagement. So next slide. So today, as we're focusing on community engagement, I just put this slide here to show what we considered community engagement prior to the federal EHE plan, and then what we consider community engagement after the federal EHE plan. So I won't read everything, but I will highlight after the federal EHE plan, what CDC wanted everyone to do, or what was laid out in the NOFO, is continue to do everything you've been doing. So everything at the top arrow, the community planning groups, the community advisory boards. However, we want more emphasis on ongoing community engagement, new partners, new voices, and innovation were some of the highlighted things in that NOFO. Next slide. So what is NACCHO doing? That is what everyone wants to know. What are you doing as an organization or within your team? So within our team, we have been leveraging our connections with local health departments, convening them as EHE jurisdictions, Part A jurisdictions, and really trying to assess the needs and concerns and to determine what are the barriers to community engagement. How has COVID impacted community engagement, and how has COVID impacted your EHE programming? What do you need from NACCHO as an organization, and what are the gaps? So we know this will look different depending on the locality. Also, partnerships has been key, making sure that we are in close communication and partnership with organizations like ANEA to get a better understanding of what's going on at the community level. Although we, are the voice of local health departments, we need to know what is happening. We need to know the barriers and the concerns so that we can also relay that information to the local health departments and encourage them in any way that we see fit. Also with that, and Christina will go more into the NASTAD 19-1906 grant, but we are sub-awardee with NASTAD as well on that grant and on the HRSA side on the systems coordination grant, which is just very beneficial, very exciting. So we're able to have a more coordinated approach at the local and state level, at least between the national organizations, and hopefully be that example in other areas, but because that has been asked for as well. And then lastly, one of the main things that we do at NACCHO is facilitate peer-to-peer learning for local health departments and sharing of best practices. This is something that local health departments continuously ask us for. They want to hear the success stories. They want to know or be in contact with other health departments that are doing something well, such as community engagement. Next slide. So as I previously mentioned, we have convened the EHE jurisdictions. We have spoken to our own members, our own work groups. Of course, we have spoken with ANEA, and there are some needs and some concerns, which is why we're having this webinar on both sides, local health departments and the community side. I know one thing that we have been hearing from local health departments is just this new and unique funding stream with this NOFO that specifically called out the 48 counties, that specifically says, the plan should be localized, but then the funding is being positioned within the state. And so it's just a unique situation that I think is new to both states and localities, where you were either funded as a state health department or directly funded as a county in some counties, or directly funded as a CBO. So now things are just a little different. So it's just more need for communication, more need to engage each other. So it's just some work that needs to be done there, and that is a concern with local health departments. Also, conflicts with pre-existing either state or jurisdictional, at that time, ETE plans. Like I mentioned before, a lot of jurisdictions already had their ending the epidemic plan. So then how does this new plan fit with that? And then, of course, COVID implications. A lot of our health departments, we did a query in, I believe it was May, maybe before that, on local health department impact on COVID on their HIV, STI, and viral hepatitis programs. And they basically let us know that a lot of their staff were being redirected to work on COVID. Specifically, a lot of the STI and HIV staff were being reassigned to work on COVID. There was a lot of suspension in programming. Basically, most of the prevention programs, to include PrEP, HIV, and STI testing. And then in some clinics, they were only able to test symptomatic cases with this. I know, people are moving into phase 2 and phase 3, so I don't know if this has changed much, the implications of that. I don't think so, since staffing was an issue even prior to COVID. And then what is needed from local health departments? They have expressed just a streamlined approach at the federal level, examples, and then basically how to engage community, especially in the time of COVID. And on the community side, we have heard just concerns with community engagement or lack thereof, and stronger terminology in the NOFO. Right now, when I read the NOFO, it says things like, you're encouraged, speaking to state and local health departments, you're encouraged to work with community, or you should do, which language is just not as strong, and we have heard that from community members to beef up that language a little more. Also, one of the main things is community members are not seeing their what they express in the plans. They're not being part of the strategic planning or the implementation. So it's more of being a participant and being captured in the agenda or being captured in the notes, but not really being part of the planning is what we are hearing. And then some have just not seen the plans at all, like Edric said, which is another main concern. So I think, it's different with each jurisdiction. Some are doing well, and some there's some room for improvement. And I think just transparency, I put it on the community side, but this can really go both ways, even us as national partners. Lack of transparency is just creating a lot of skepticism within the EHG efforts. So that is something that definitely we can work on and discuss further. Next slide. So now I want to move on a little bit and talk about how local health departments are trying to address some of these concerns and find a workaround. Next slide. So local health departments are trying, to be creative with, it's been some difficulties, especially with COVID. But one jurisdiction in particular explains to us how they were using food delivery services to provide lunch during EHG virtual community planning meetings. I thought it was brilliant. Of course, if you want to know more about that, I have to put you in contact with them to see exactly how they're doing that. But I thought that was a great way to offer that and try to increase participation. A lot of local health departments, because they have no other choice with social distancing, are using technology to engage community, so online focus groups, virtual meetings. But they also noticed that although, technology is useful, it's not the answer. There are so many issues with technology, rural areas, you may not get that connectivity. So they do acknowledge that as well, but it is an option. And even some of them mentioned after COVID, they would still use it as an option, just so people would be able to attend without fully disrupting their schedules. And I briefly want to just talk about one actually innovative strategy health departments are using a lot, but one particular way to expand HIV, STI services, especially in the time of COVID and just in general. So I want to highlight Baltimore City Health Department and Johns Hopkins. Just here, I want to point out that Baltimore City and Johns Hopkins basically leverage each other. Baltimore City leveraged the infrastructure and expertise that Johns Hopkins already had in place to host an online HIV testing portal to provide HIV self-test kits to the community. In Denver, which is a unique situation, smaller health department, staffing capacity was an issue, but they found a workaround to partner extremely closely with OraSure, so that OraSure was the ones that was sending the HIV self-test kits, tracking it, mailing them, and then, of course, providing within each test kit the Denver local health department information. So health departments are really being creative. In Charlottesville, they use social media to conduct outreach and provide self-test kits, especially when stigma and transportation are huge barriers in that area. So they are, local health departments are trying to find ways, and this is why the success stories is very important, and being able to share their stories and hear from community, certain things that are working and what's not working is very important. Next slide. And I wanted to touch just a little on harm reduction community engagements, where when we talk, we have a work group, community of practice for SSPs, and as we talk to our members, local health departments, partnerships is just key with harm reduction, and specifically with SSPs, and local health departments are working closely with partners, closely with community and people with lived experience to gain insight, and also to have those people with lived experience offer peer services has been very key community engagement component. In the time of COVID, they have been forced to be a little creative, especially with SSP programs, but they have been either co-locating services with CBOs, using mobile services to expand access to the community, offering hygiene and hand washing stations, increasing the number of syringes or supplies that they're using, or even using mail-in options. So they understand that, SSP comes with already a lot of barriers and challenges, and they just do not want to take that service away from the community. So these are just a few examples of what local health departments are doing to engage community and try to sustain their programming, but they are very open to other strategies, and I'm really looking forward to hearing what people on the phone have to say today about maybe some creative ways or suggestions for local health departments. Next slide. And just to wrap up, I just wanted to say to please use NACCHO as a resource to help either facilitate a discussion between community and your local health department. We can definitely do that. Offer any suggestions on community engagement or strategies that you want us to share with the local health departments, or even if you want us to share with federal partners. Please just consider us as that resource, especially during this time, but at all times. And I will close there and let Christina take over. Thank you, everyone.
Thank you, Tisha. So I'm going to introduce Christina and then turn it over to you at NASTAD, Christina. So we're lucky to both have Tisha and Christina join us today. Christina is the Senior Manager of Prevention at NASTAD, and she supports her team by providing capacity building assistance, technical assistance, and community engagement for phase 1 ending the epidemic jurisdictions. And Christina, if your mic is on, could you mute yourself for just a second? So Christina also leads staff activities related to housing for people living with HIV and Latinx, HIV, and hepatitis issues. So prior to NASTAD, Christina worked as a housing case manager for people living with HIV in Cleveland. And Christina received her MPH from Case Western University with a concentration in health policy management and a BA in public policy and Spanish/Hispanic studies from William Smith College. So we're really lucky to have Christina with us here today. So let me pull up your slides, and then I'm going to let you take over. All right, Christina, it's all you if you're ready.
Thank you, Edric. So thank you for introducing me. Today, we want to give a little bit of information around what NASTAD has been seeing around community engagement, as well as share our role within 1906 and the EHE initiative at large. So next slide, please. So first a little bit about NASTAD, for those who may not be familiar. We are a nonprofit association that was founded in 1992, and we represent all the public health officials, so the directors who administer the HIV and hepatitis programs throughout state and territorial health departments. So this includes, again, all the 50 US states, the District of Columbia, Puerto Rico, the US Virgin Islands, as well as recently within the past several years, we also provide support to 7 local jurisdictions who receive direct funding from the CDC. Our role is really to provide capacity building and technical assistance support to these health departments, and we do that across several different areas within HIV and hepatitis. So we categorize ourselves across teams, but we really work collaboratively when needed and when necessary. So our teams include prevention, healthcare access, drug user health, health equity, hepatitis, and policy. Next slide, please. Our mission is to end the intersecting epidemics of HIV, viral hepatitis, and related conditions. And our vision is a world free of HIV and viral hepatitis. We really also have been, over the last several years, we've been really pushing to approach all the work we do, not only from a health equity lens, but from a social justice lens, since we know the relationship that social justice has with quality of life and quality of health. Next slide. So as was briefly mentioned before, NASTAD is the National Technical Assistance or TA provider for ending the HIV epidemic initiative that was announced by the federal programs. And basically what this means is that we are the entity that will be providing support to all of the EHE phase 1 jurisdictions. And to give you an idea of how we do this, we included just some of the ways that we provide TA support. So the first one is through trainings, and these are really personalized trainings depending on each jurisdiction, their needs, their where they're trying to focus their work and efforts on, and any feedback that they've received from community. So as it relates to community engagement, we would again deliver any personalized trainings to the jurisdictions identified within the initiative. Also, we offer peer-to-peer calls, so it's really connecting health departments with peer jurisdictions to discuss strategies that they've employed. We have various webinars across various topics. We recently had a series on the relationship between digital technology and community engagement as a response to COVID, as well as a response to the continuation of EHE planning. We also have been working on developing resources and tools that really look to strengthen the efforts within EHE. And again, this crosses various topics, including community engagement. And lastly, as Letitia mentioned, we have created a national partnership, which is really a coordinated support system between national partners that include NACCHO, NCSD, and CSTE. Next slide. Okay, so I wanted to give you just a brief overview of what our trainings include. So I'm not going to go through slide by slide, but just wanted to share what it is we include. So next, click next, please. All right, so community engagement. We really consider this an ongoing cumulative process that is really looking at centering building trust with community and centering their voices and perspective. Next slide, please. When we are doing our community engagement trainings, we're really looking at these principles, and these were developed by the Kerwin Institute for Racial Justice at The Ohio State University. And these are the core principles of community engagement that they developed that we really feel should be the center of all community engagement work that health departments are undertaking, particularly if they are looking to build partnership and trust with community. Next slide. And then also within these trainings, we also like to approach it as a strong community before strong programs, given the fact that engagement level may vary from person to person or agency to agency, as well as engagement needs may change from each community you interact with. We provide just general approaches that health departments and community organizations can take when they are starting to engage in community engagement work. And that really includes center outreach as a process, not a one-time event, communicate a clear understanding, identify and come to a consensus of what you would like to prioritize, learn what transparency means across the various stakeholders who are involved and what the expectation is to maintain it, as well as assess ethical considerations and treat individuals as autonomous agents, as well as protect those with diminished autonomy. And this centering your work around these approaches and ideas really is the foundation we feel around creating authentic and meaningful community engagement. Next slide. And then lastly, I'll go over the other concepts that we address within the training. So this is just a sample of most of the things that we cover within these trainings, including eliminating hard to reach. And I want to clarify, it's not eliminating the idea, it's eliminating the idea of hard to reach, not working to reach individuals we have deemed hard to reach, because the term hard to reach puts a lot of onus on the community, and we want to reevaluate that and really look at it as being the responsibility of the health departments and community organizations to create an environment that is welcoming for community, particularly those who are often forgotten or left out of the conversation. We also include values recognition, as well as cognitive dissonance, privilege, power, oppression, stigma, autonomy, implicit bias and prejudice, identifying limitations within your own organization, and how to create institutional consistency when you are engaging and outreaching to community. So next slide. So along with 1906 CDC's National Cooperative Agreement, there is also, NASTAD is also the recipient of SEBA supplemental funding. And this supplemental funding is specific to community engagement within the ending the HIV epidemic. And for us, it's particular to the southern region of the United States. Other national partners have received supplemental funding to focus on other regions of the United States. So this work is happening nationally. It's just that NASTAD will be solely focusing on the southern region. And this funding is really looking at three major pieces to expand partnership within community engagement and potentially leveraging the relationships and resources you have to create new voices within the EHE process. So how we are approaching this project is that we at NASTAD will be reaching out to health departments, community organizations, and community individuals who would like to participate, and having conversations, focus groups, informal meetings with them to really get a sense of what their perspective around community engagement has been with their jurisdictions, as well as what they would like to see within community engagement moving forward with the plan. And this will also include what new partners they would like to see included in the process. So again, we're also going to be focusing on partner building, so expanding those existing community engagement partnerships and exploring new partnerships for the process. So again, working with the health departments to see who they may have engaged already, how they're engaging them, and if there are any new partners that they would like to welcome into this process. And then the last piece is going to be resource development. And this is really looking at development of tools and resources that are helping to strengthen community engagement within EHE, as well as outside of EHE, because there are still other programs that may not be identified within EHE that could still benefit from these community engagement tools. Overall, with this supplemental project, we are hoping to create a sustainable foundation that allows health departments, community organizations, and community participants to move forward to build the meaningful community engagement that they need within their respective regions. Next slide. So the last thing I'll talk about is wanted to give some jurisdictional examples. And the first one is with Central Florida. So they partnered with United Way Heart of Florida, or Heart of Florida United Way, to collect information for their EHE strategy. And in June, they actually presented on the work that they're doing on a webinar for NASTAD. And you can access that on our EHE website, which it's linked to on our 1906 page. So with this, they had initially identified that they wanted to do key informant interviews, listening sessions, community surveys, virtual town halls to gather input, but then COVID hit. And so what they decided to do was move these to Zoom. And so they held their EHE community feedback sessions over Zoom. And what they did to kind of elicit more engagement was they used audience polls, breakout rooms. They also included captioning options for those who are hearing impaired. And then the next step that they did is that they took those Zoom sessions, because they did have a limited number of spots within it. They took those and then they broadcasted those sessions over Facebook Live. So there was a whole new subset of individuals who may be connected into their social media, who were able to see these listening sessions and interact with the health department in a way that they hadn't typically interacted before. Also, there's East Baton Rouge, and they were one of the pilot project spots for EHE. They began their EHE planning several months before most other jurisdictions because they were a pilot project spot. And with this opportunity, they immediately hired a coordinator that would help support the goals and efforts. They identified goals within the plan that really tried to be reflective of the community feedback and their needs. And then they established several committee meetings that frequently met to provide updates in the progress plan. This also created a check-in loop for East Baton Rouge with their community members and the health department. And then lastly, two other things that they did actually is they hired community health workers who went into the community and started to work closely with folks to provide them resources, not just resources related to HIV prevention and care, but looking also at food assistance, Medicaid, things that folks may have to go into their case managers to see. They were taking it out onto the streets. And now the last thing is that they also deepened their relationship with their mayor's office. And they really got the buy-in from the mayor's office around the EHE initiative, because they really believe that having that buy-in across all governmental and communal levels was and is crucial to the success of their plan. Next slide. So then we'll talk about Maryland. And as they were developing their EHE plan, they realized that they didn't have a process in place to report back any feedback or information shared from communities, particularly those that were disproportionately impacted. So they're specifically talking about the transgender community, the Spanish-speaking community, and youth. With this in mind, they decided to dedicate specific HPG meetings to those communities. They're calling them targeted stakeholder engagement HPG meetings. They will begin this month and they will culminate in 2021. One new approach that they're taking is that they are inviting new voices to these meetings by inviting experts outside of the field of HIV into these meetings. And these are experts who work specifically with the identified populations that they want to focus on for these meetings. And they're asking them how they, what strategies they employ to communicate and connect with community. Since like with HIV, if they are working, for example, in diabetes, how are they connecting with young folks who may have type 1 diabetes and getting them the information and having those conversations. So they figured that there are folks outside of HIV who may have expertise, and this is a great opportunity to bring them in and have conversations with them and with community around what is shared. And lastly, they are also revisiting existing social marketing and social media campaigns and looking to potentially update and reinvent those. They're putting a spin on it by essentially asking community folks to share their ideas and concepts that they can include in the campaigns. They're really approaching it as a by Marylanders, for Marylanders idea around updating these campaigns. Next, we have Baltimore City, and they are looking to expand their People Who Look Like Me social marketing campaign. And this campaign has been a labor of love over the course of 4 years. So over these past 4 years, Baltimore City has worked to create, develop, and promote this campaign. And they're really planning on using the EHE initiative as an opportunity to expand it. They really wanted to focus on the storytelling aspect and center community voice. They approached it by having smaller, more intimate meetings, recognizing that when folks share their story, it may put them in a position of vulnerability and discomfort. So they felt that these smaller intimate settings would kind of help address some of those discomforts that may come up. Additionally, they set up feedback loops for community as they develop the campaign to really ensure authenticity in the vision and try to avoid tokenization. And ultimately, this was a community approach and really intended to put the power back in Black and Brown folks who have been overly impacted by HIV and health inequities within Baltimore City. Next slide. And the last jurisdiction I'll talk about, which isn't directly related to EHE planning, but I think is a good example of innovation, as well as they are exploring how to potentially use this, is Indiana. They have a program called Continued, and it's a patient tablet access platform that gives their ASOs the ability to rapidly deploy telehealth to clients facing barriers by accessing telemedicine. So this program provides eligible clients with an 8-inch tablet with a mobile data connection and a simplified interface that really allows the clients to better engage with the care team and really focuses on providing holistic care. Each client's tablet can be customized to include tools necessary to their own care, And it's really a team effort that is a conversation between the client, their care team, and the programmers for this program. It really gives clients not only greater access to their HIV care, but also other services like transportation or mental health or legal services. And it really has shown to greatly reduce the no-show rates for both the digital and in-person appointments. They have expanded this process or program with COVID-19, and again, are exploring other ways that they can further expand it. Next slide. So just in general, some of the challenges that jurisdictions have communicated with us is obviously COVID-19. As Letitia said, there have been staff who have been deployed to other areas or deployed to COVID-19 and have not been able to really focus on the programming within HIV. So that has been a concern, as well as the communal impact of COVID-19. There have been struggles with administrative buy-in, just in terms of how they are wanting to engage community versus how they've traditionally done it. You know, activities have been politicized, whether it's on a state or local level. And then, you know, you had existing community mistrust, and all of these factors then add to additional community mistrust. And that is a huge barrier that health departments are trying to overcome. And then the last challenge related to COVID-19 is the competing priorities, both for community and health departments. Due to the pandemic, due to the social uprising, you know, these program staff within the health departments, they're also experiencing the pandemic and the social uprising and having a real world impact by it, as well as the community. And it's trying to find that balance between the two and push the work forward in a way that feels genuine for both community and the health department. Next slide. So that's what I wanted to share. If you do have more questions or information, you can reach out to Angela Johnson or Emily McCloskey. I should have mentioned prior, but I forgot that our 19-1906 work is not just programmatic, it does also include policy work. So Emily and her team have been brought in and working very closely with Angela on the policy implications and impacts of EHE. So thank you.
Thank you so much, Christina. That was great. Really great presentations from both NASTAD and NACCHO. So now we're going to pivot over to some questions. Let me just pull up my slides so we can in the background. So we've prepared some questions for both NASTAD and NACCHO, and also have a few audience questions. Those presentations really covered a lot of ground, so really appreciate that. And since we just talked about representation and the importance of community buy-in and building trust, I think I'll start with this question is, how are y'all encouraging health departments to hire and prepare leadership from the most affected communities? So getting the representation to actually be the leadership within health departments or community-based organizations.
Do you want to go?
So you can go. I was going to ask, Edric, do you mind making our director, Lucy Slater, a panelist? And, oh, I see. Never mind.
Just did it.
And I'll also say that I've invited Angela Johnson onto the Q&A portion. So we're gonna tag team this Q&A portion.
And while we're sort of getting adjusted and getting settled, I'm happy to take a first stab at this one. Again, thank you, Christina. My name is Angela Johnson, and I work closely with Christina. So a few things, even before even before the EHE work, the federal EHE work, NASTAD has really been trying to figure out ways to amplify the communities that are most impacted by HIV, and sort of increase not only hiring within the workforce, but also support for those individuals and leadership opportunities once they have been hired. So for a number of years now, NASTAD has coordinated our minority leadership program that is specifically for health department staff of color at various levels throughout the leadership hierarchy, and work to really intensively equip them with the skills that are necessary to embody in order to continue that promotion, opportunities for promotion, but also to be able to feel confident and assertive in whatever position they are currently in. It's been a great opportunity for health department staff of color to not only learn more and network with their own cohort, but also to connect with previous cohorts of the minority leadership program, and sort of build out a national network for folks to be able to support one another. We also collect data through our, for example, our National HIV Prevention Inventory, where we look at a lot of different areas that are impacting the current landscape of HIV, and one of which is workforce. And we looked at both a number of different categories, racial and ethnicity, as well as gender identification and sexual orientation, to see what populations are showing up in the HIV workforce and where are we seeing a lot of gaps. And I think that it's probably no surprise to anyone that we're seeing very small numbers of health departments that are actually reporting that the majority of their staff reflect those in the community. So we are trying to sort of stand with the data and show that, you know, if you're saying out loud that your health department is diverse, but when we ask you to show us the breakdown of the numbers, this is what we're seeing, then those are avenues that we are able to use their own data to be able to bring that up as well. And as we're reviewing the plans, you know, I think that a lot of people have noticed that the kind of graphic for the federal EHE pillars has changed a little bit from when it was first announced. Originally, there was a fifth pillar that was dedicated to HIV workforce, and there was a little bit of fear among stakeholders when we saw it kind of disappear. But it's not that it's disappeared. It's more so that that there's an expectation that HIV workforce will be integrated into each of the four pillars. So when we're looking at diagnose, treat, prevent, and respond, how are we addressing the gaps in the HIV workforce and implementing ways to increase the HIV workforce within those four pillars? So when we're looking and reviewing the plans and looking for opportunities for technical assistance through that, that's one of the things that we are looking at as well, to see what is your workforce already looking like, both within the health department and with who you are funding. You know, I think that this not only goes to the makeup of the health department itself, but who the health department is prioritizing at the community level to be able to fund. And are there community entities that may be underrepresented, but may be very impactful for subpopulations that may not have enough capacity to compete against some of the larger CBOs for this funding for the health department? How can we look to encourage health departments to reach out more and provide platforms to be able to sustain them as well? So those are a couple of things that I know are high on our radar at NASTAD, and are things that we've either been working on even before EHE, before the federal EHE initiative, as well as within it.
Great, that was a very thorough response. And if there are no additions, we can move on to another question. Does that sound good? So y'all touched on a lot of sort of the updates on what's been going on across the board in these jurisdictions. The question that stands out to me still is what is being done to help the jurisdictions get access and maintain access to the jurisdictional plans and the feedback that's already been provided.
And I laughing. But Angela, do you want to?
Sure, I'll take this one away as well. So I think what's important here to note is the concept of timelines and the significance of dates. So I think that none of this is new to probably anybody who is involved enough with ANEA to have heard about this webinar, but I think it stands repeating. When the jurisdictions were required to submit these draft plans by December 31st, 2019, it was a surprise to all of us involved. The funding, the year one had already begun. And health departments had, when they applied for the funding, the anticipation was that they would have 12 months to really get down to the details of how they were going to engage community in new and innovative ways to be able to give the attention that it needs to each part of the plan. So when they found out after the award had already started that these draft plans were due in less than a quarter, which also overlapped with holiday time, then in order to just get something on paper, a lot of health departments really did just use the information that they already had so that they could kind of check that box and submit something to CDC so that they could actually get down to doing the work that they're doing. Now, because of this, there are a number of reasons of why the plans haven't been made public. One, because being frank, a lot of the plans that were submitted by December 31st left much to be desired for the reasons that I just mentioned. Also, when CDC requested them, there was no language that was already written in to say that this would be made public. And because of some of the legal ramifications, CDC just can't automatically do that at this time. And full disclosure, as the technical assistance provider that's funded by the CDC hasn't even given us the plans. So the only plans that we actually have access to are those that the health departments have either shown us either in their entirety or either snippets of it as we are providing technical assistance with them. Another important deadline is that all jurisdictions received CDC feedback on by March 31st of this year. And that feedback was to the plans that were submitted back in December. Now, a lot of what we've heard, excuse me, from some jurisdictions is that by the time they received that feedback from CDC, they had already started working on some of the things that they already knew that they had gaps on. So when they submitted these plans the end of December, and we reached out in early January to start assessing TA needs, they were already able to tell us, this is what CDC is going to tell us is lacking in our plan, and we know that it is, but we finally have time to actually get down to doing that work. What we've heard from health departments is that they don't want to do a disservice by making public certain aspects of the plan that they know they have a plan in place to continue to engage community. And if different aspects of community hadn't been engaged before that December 31st deadline, it does not mean that the health departments didn't already have a plan to do so in the coming months. Again, they're under the understanding that they're funded to plan through September 29th of this year. So the next deadline being August 1st, we hear, okay, now they've been funded to start implementation starting August 1st, but some of us still haven't seen these plans. Even though implementation does start August 1st or started August 1st, CDC extended the planning period through the end of the year due to complications with COVID. So although health departments may begin to implement certain aspects of their plans, they are still actively planning through the end of the year. So I say, I know that there has traditionally been a lot of instances of mistrust between community and governmental public health. And I would say that if at this point you still have not been actively engaged or you don't know who your EHE point of contact at the health department is, you can reach out to NACCHO or to NASTAD and ask that question. We've reached, Christina provided the link, I believe, for our EHE microsite that we are all contributing to, and we are working on making public the contact information for each health department EHE lead at the phase 1 jurisdictions. And after the final plans are released, then we plan to house them on that public facing website as well. Some jurisdictions, some ways that we've been trying to encourage jurisdictions to at least show where in the plan they feel confident and where they feel like they need the most help with. We've been encouraging them to make some kind of a public facing website so that way community who they may not have already reached out to or may know that they are leaving them out of the conversation, the public will have access to that platform and then can sort of bring their own selves to the table as well. An example of this is Philadelphia. They have a public facing website that has the current status of their draft plan. It also has laid out, these are our upcoming community engagement activities. If you see that you are not included in this, please come and reach out to us because we want your involvement. So all that to say that I think all parties are aware that it feels like these plans have been held behind closed doors. And think of it as if you're working on a term paper, do you want the professor that's going to kind of grade it to see your original rough draft if you know that it's not like your best effort yet? I think the health departments want to be able to put their best foot forward. So they want to make sure that they're not going backwards by showing something that's kind of thrown together, so to say. I apologize. I tend to be long-winded. So I'm going to shut my mouth and see if anyone else has anything to add there.
No, that was a great and thorough answer. Really appreciate that. So I'm going to move on to some audience questions. So again, please feel free to submit your questions in the question box. One that we got pre the presentation with registration was, will NASTAD and NACCHO do a rigorous comparative analysis of EHE budgets and services? So the budgets, is that something that lands in your camp?
It does not. So we are not the agency that's providing the funding. Our role is solidly within providing technical assistance. So we wouldn't, the way that funded entities have to report back to their funder and sort of justify some of that, we don't have access to that kind of information.
I mean, I would add to that. I mean, so that's a question about sort of transparency and utilization of funds by states. But there's also an aspect to that around sufficient funding to be able to implement the plans as written. And so both NACCHO and NASTAD are organizations that have advocacy shops. And as Christina said, NASTAD is funded also around policy work on this as well. So, I mean, I think in terms of being a supporter and advocate on behalf of both governmental public health and community to ensure sufficient funding for EHE, NASTAD and NACCHO want to be there. So.
Got it. Good to know. We'll keep that funding conversation in the back of our minds. So next question that we have is from the chat. How are you sure health departments are working on EHE and who is making them accountable for not working? Many don't like working with community who are actually doing the work on the ground. And this person went through all the US Health Department's website, and most only talk about prep for prevention and have forgotten that people living with HIV also need a prevention plan, as well as to learn about how staying adherent can help end transmission.
I think I heard the first part. I think it was about accountability. So I'm not going to speak too much on the NOFO and what's in the NOFO and what CDC has said as far as accountability. But and their checks and balances, because they do have something in place. But I will speak more for NACCHO and NASTAD. If you are experiencing any challenges within your jurisdiction, we definitely want to know, either to us directly, or if you want to contact ANEA, ANEA can contact us. But if there's a conversation that needs to be had, or there's an opportunity to address a concern, we don't mind facilitating that discussion. But in order to have that accountability, we would need, to know what's going on in order to address that situation. but I'll leave it. Angela or Lucy, or have anything to add?
I was gonna punt back to Christina to say a little bit more about the SEBA supplemental funding and sort of why that came about, and sort of the focus of that. And I know that you mentioned before the 4 regional SEBA providers that are funded for that, but if you can briefly just say sort of who those partners are, and just give a little bit more context there. I think that this is something that we didn't know was coming, and until it came, and I think that it was due to a reaction of hearing that there was more needed involvement in terms of accountability at the community engagement aspect.
Yeah, thanks, Angela. So with the SEBA supplemental funding, the 4 entities that will be administering this project are NASTAD. In the Northeast region, it'll be the New York City Department of Mental Hygiene and Health, I believe. And then for the Midwest, it will be AIDS United. And for the West Coast, it will be the California Prevention and Training Center. And really, as Angela alluded to, this really came about, we believe, from concerns that CDC was having around the lack of true innovation and push to further community engagement within their EHE plans, and really thinking through how do we use the tools that we already have and use the knowledge that we already have to welcome folks into this process in a way that hasn't been typically done before. As I said in my slides, there's power dynamics at play here, and typically those power dynamics have been imbalanced, often leaving community unsatisfied with the way that health departments may involve them in the process or represent them in the work that's being done for their health quality. So with the SEBA supplemental, how NASTAD is approaching this is that we are trying to actively work with the health departments and connect to their community. The largest and most upsetting challenge of this all is that the SEBA supplemental project is only 8 months. So it will only go until March 31st of 2021. Now that is not a lot of time to build a relationship and trust with community between NASTAD and the community. We recognize that. So really we are trying to focus the attention on setting levels of accountability within the health department to push the innovation that they have within community engagement and help them realize ways that they can center community's voice, ways that they can center community's role and responsibility within EHE, and allow them to be leaders in this work alongside with what the health department is doing. And I'll add that, kind of circling back to the first question, I was thinking there was a jurisdiction that even prior to EHE, they had started implementing a leadership development program within their HPG, and really looking at how to do the capacity building for health department or for community members, so that they're not just showing up to meetings and feeling that their voices are not being heard and reflected. So this is something that we're also exploring within the supplemental, how we can further support this, if it's possible, depending on the jurisdiction, but really looking at bridging community and health departments in terms of how they're communicating and interacting, to ideally address some of that medical mistrust and historical trauma that still exists between health departments and community.
Thank you. We have one more question in the chat. So what are the plans to implement more messaging around U equals U for the community and to ensure that this information is required to be provided to all newly diagnosed type patients and readily available for anyone? And how can we be assured that this will be implemented into EHE plans.
I don't want to jump the gun again, but NASTAD keeps up to date a list of which of the directly funded health departments have officially signed on to U equals U. We can forward that the direct link, Edric, in case you want to forward that out to the registrants here. So that way you're able to see sort of in real time which of the health departments have already signed on to it. We are always kind of actively encouraging more and more health departments to work within their states to sign on to that. And even for those that have not already formally signed on, what we've been hearing is even if they've not been able to overcome the challenge of being able to sign on at the state level, that they are overarchingly working to promote that message. I can speak personally and say that from the draft plans that I've had access to see, we're seeing that message. We're seeing that message throughout, and we have put together kind of sort of a checklist of suggested ideas as we are able to have access to the plan, so that we can see, if a jurisdiction requests technical assistance about A, B, and C, then we still use that opportunity to say, hey, I noticed that I don't see this in your current plan. Is that something that you all are working on adding in? What are some challenges that you're seeing in that vein? So I feel pretty confident in saying that from the plans that we're seeing and the conversations we're having, that's an active part of the conversation, even if at the state government level they have not officially signed on. I don't know of many plans that are giving pushback to that. Yeah.
Yeah, I would love it if you could circulate that list of health departments that have signed on.
And I'll also say that in our part of our role is to liaise between the CDC funded health departments and the CDC themselves, or with all of the federal partners. And since NASTAD first signed on, we have been pushing CDC as well to say, stop talking about effectively, it is like, just say what it is. And we've put out a number of issue briefs and included in language for things that we are producing as an entity that is receiving funds from CDC. So even in our own conversations, we continue to give pushback to our federal partners to be explicit in the language and what it means, because we know that if they are saying it at that level, then that gives the jurisdictions more grounding to be able to stand on it at their level as well.
Awesome. Great. So we have time for one more question. So this last question is from me. So as the Act Now and AIDS Coalition, as a community coalition, what can we be doing as a partner to y'all to make sure we're tracking some of these community engagement efforts more? What would be helpful to see to y'all? We can sit on this question if we have to.
Well, I'll speak, and Lucy, you just wrangle me in if I get, but I'm just more of a straight to the point type of person. And I really want to know, like, if there are challenges, we need to face them head on. So if there are, I don't know, specific challenges that ANEA is hearing, please let us know. Like I said, if that means a conversation, then that's a conversation. That can be state, local, and community in that one meeting. So I just like for us to address it head on. There's unique situations, and then there's some themes that may go across. And as we're doing our EHE efforts, we might be able to find a way to address the themes. But if there's specific things, we really want to know that. And I speak for NACCHO and probably NASTAD on that one as well.
Yeah, I mean, I would add to that. I mean, I think Christina already sort of pointed out in terms of, basic principles for community engagement, and that would be applied here between the relationships between NACCHO and NASTAD and ANEA, and all of them, all of our, members, is that there needs to be an ongoing communication process and a commitment to that, and to building each other's capacity for communication and engagement with each other. So, we're committed to that.
I'll just add that in addition to the challenges, we also want to hear your successes. Like if you know what's going on in the community and from your health department, and it seems like it's been a success or something's working well, let us know of that too, because since we are in a national position, we can also bring those stories to the forefront, to our federal partners, to other jurisdictions, and share those successes. I'll also do one last plug for the SIBO Supplemental, and if you are in the South or the Southern region, specifically Kentucky to Delaware and South, and then Oklahoma and Texas, I want to hear from you as well, because as we really jump into the SIBO Supplemental project, we're really trying to focus on bringing the stories from community to the forefront as it relates to community engagement.
And I'll round this out and say, for what Christina said, also to give that shout out in the same thing for California PTC for the West, AIDS United for the Midwest, and New York City Department of Health for the Northeast, because they are working towards those efforts as well. I think, it would be helpful. I think sometimes we put forth resources that make it to the health departments, but may not make it out to community as a whole, that I think may be relevant. And one thing that I'm thinking about in particular is we did a request for information to do a little assessment about how COVID is impacting health department capacity. And we released we released a brief about the findings from the first one. And we did a round 2 that we have the brief maybe coming forward maybe next week or so, but it really looks at, like, for instance, seeing that I believe it's 75% of HIV program staff or HIV prevention programs have a significant number of staff that are deployed to COVID during this time. So it's like, it's things that we know kind of broadly, like, okay, we know that staff are being deployed to COVID. We know that that health departments are having challenges keeping people engaged in care during this time, and also with their outreach and testing. But what do those numbers actually look like? So these are things that NASTAD has put out as well that I think sort of help bring data and numbers to some of the conceptual ideas that we kind of know. And I sort of stand on looking at the data. Like, I feel like it's hard to make movement if you don't know what reality is, right? So and that's something that we can talk about offline, about if there's a better way for us to kind of funnel information to you that would probably be beneficial to ANEA's audience that we've traditionally just been sending to our membership.
Yeah, I think that would be great to get it to the community orgs that are not traditionally involved in those efforts. Well, thank you all so much. This was all very useful. I hope everyone on the webinar enjoyed the time together. So I'm going to just close us out by thanking everyone again. Christina, Letitia, Angela, Lucy, thank you for answering questions and for the great presentations today. So we do have some upcoming coalition events. I encourage everyone to check out our website, www.anea.org, to follow us there. You can also email me at anea@treatmentactiongroup.org and like our Facebook. That's it for today. Thanks again, everybody.
Thank you.